Welcome back to Your Health television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and I'm delighted you could be here for this next segment because I have the illustrious board-certified expert spine surgeon, Dr. Mark Howard. Dr. Howard, thank you so very much for being on the program.
Thanks for having me, David.
I'm delighted to have you here. Dr. Howard, I'm just reviewing your very impressive resume, Harvard Medical School, Boston, and you did a full orthopedic residency, correct?
Yes.
Now, let's teach the audience what it means to do a full residency and then to go on and do a fellowship, for example, in spine surgery. What do we mean by that?
Well, our training is very similar. As you know, all of us do an internship, and that's a general year where you study and participate in many different disciplines, and then you split off and did plastic surgery. Well, I spent 4 additional years doing just orthopedic surgery to learn that specific discipline. But within orthopedics, there's many different specialties, as you know. So you rotate between joint replacement and sports medicine and spine surgery and pediatrics and deformity. So you get kind of a general broad breadth of all of orthopedics. As you know, I then went on and did 1 additional year of just spine surgery fellowship where all you do is spine surgery. So essentially I did 5 additional years beyond the internship.
Perfect. So Dr. Howard, I think it's important to emphasize that you are board certified and you got recertified in orthopedic surgery. So you could have, after your residency, go in and just go out and practice and be an orthopedic surgeon.
Correct.
But instead, you chose to do a fellowship in spine surgery, and my goodness, you've been in practice 20 years or something like that.
In this community for 22 years.
22
yes.
years. Well, I'm sitting with a true expert in spine surgery, board certified. So Dr. Howard, I like these segments where I learn a lot. What I want to do is just talk about the basics of the diseases and conditions that you treat. I want to talk about disc disease, what we mean by a ruptured disc. That's kind of a layman's term, but I want to learn about disc disease. If we could explain to and teach our audience what we mean by a radiculopathy, maybe we could touch on sciatica, maybe we could touch on spinal stenosis, and we could talk about what a laminectomy is, and then we can talk about less invasive mini procedures or micro procedures, etc. So how about disc disease? What do we mean by disc disease, whether it's in the cervical spine or down in the lumbar spine?
Well, as you know, we all age normally and gracefully. In the spine specifically, that process actually starts in our early to mid-20s. So our discs, if you will, are the healthiest that they'll probably ever be when we're 18 or 20 years old. From that point on, our spine starts wearing out very much like our skin wrinkles, our hair turns gray, and so forth, and the things that you work on. Well, degenerative disc disease is the name, if you will, for that normal wearing out and wear and tear process. So it's not really a disease, it's the human condition.
Okay. So Dr. Howard, can we explain, you brought some models, which I think is terrific. Can we explain actually what a disc is?
Well, I have many models here. Here's a model of the lumbar spine. Each of the bones in our spine, or the vertebra, has a little cushion between the bones, and that's the disc. The spine is complicated, though, because it moves in a complicated way, actually 6 degrees of motion. And at each level of our spine, we actually have 3 joints. We have a disc, and then the back of the spine, we have 2 facet joints. The problem is any of those can cause pain and problems and wear out, and we can injure them, and they can break. So unlike the knee, which is essentially 1 joint, your low back, for example, has 15 joints. And that's why it's more difficult to care for back problems. People's spine problems is more difficult to diagnose them in many cases. But degenerative disc is that normal wearing out. What happens is the discs lose water content, if you will, but they become less able to withstand the normal forces that we apply to them every day, and they're more likely to have little tears and micro injuries, very much like ankle sprains. Well, for the majority of us, those heal up in the same way that ankle sprains heal up. But for some people, they don't heal up, or they cause chronic pain, or they can lead to further injury like a herniated disc or a ruptured disc. That is a problem where some of the inner softer disc comes out or breaks through the outer tough disc. The disc actually has kind of 2 sections. There's the outer tough rim called the annulus, and a softer core called the nucleus. Well, that ruptured disc is where some of that soft core comes out through a defect, and if it gets into this channel, that's the space where the nerves are, it can pinch a nerve. That's what we mean when we say sciatica or radiculopathy. That's when that nerve then has pain or numbness or weakness or tingling that corresponds to that level of pinching.
Okay, so the spinal cord itself is many thousands, hundreds of thousands of nerves, right? It's nerve tissue really coming from the lower part of the brain. It's an extension of the lower part of the brain, so it's part of the central nervous system. Isn't that correct?
Yes.
So the spinal cord in your model, can you point out again where the
This is the spinal canal. The spinal cord itself, which is one big nerve that looks about the size of my thumb, that actually ends up at the top of our lumbar spine. Then separate little nerve fibers continue below that, and they end up coming out of each of these little channels to the side called the foramen, and then those nerves come together to form the big nerve that goes into our legs called the sciatic nerve.
Okay, now is that the same for cervical disc disease?
Very similar. We have a different name for it, but the same concept in the neck. The discs in the neck can degenerate, they can tear, they can rupture, they can pinch nerves, and that can cause what we call cervical radiculopathy, which is sort of sciatica in the arms, if you will. And that can cause numbness or tingling or cramping or pain in the hands or fingers.
Now, let me interject for a moment. Isn't there a famous quarterback who's still playing, who recently had some cervical disc disease, and people were worried if he could come back or not? I think maybe the quarterback for the Broncos.
Yes.
So
he's a spine surgery success story, because he's actually had 3 neck surgeries, all of them at the same level. Ultimately culminated in a fusion. The first 2 were not fusions, where they went in twice trying to just do little microsurgeries to relieve pinching. It wasn't sufficient. They had to go in and do a 3rd surgery. And as you know, he's having one of the best seasons of his entire career.
Right. Okay, so Dr. Howard, again, so we've started to talk about disc disease, and you talked about the facets. Can you explain what we mean by spinal stenosis, and can you explain what we mean by a laminectomy?
Spinal stenosis means narrowing or pinching. So spinal stenosis, again, the nerves travel on this channel, which is where it's surrounded by bone, so it's protected. That's the spinal canal. So spinal stenosis is any combination of either disc bulge or arthritis bone spurs, which over time can grow and narrow that channel. So laminectomy refers, the lamina is the name of this bone in back of the spine. So if spinal stenosis is severe enough, we not infrequently have to do surgery called laminectomy, which involves taking away bone from the back of the spine to relieve nerve pinching and open up the space for the nerves. If we take the entire bone away, that's a laminectomy. If we take a portion of that bone away, that's called laminotomy, or a partial removal.
Okay, so Dr. Howard, let's back up for a moment. If we have a ruptured disc or herniated disc, does that mean the disc comes out, or can you repair it and leave it in? Can you replace it? What happens with a herniated disc?
Well, a couple things. If you truly if you're a younger person, and as I get older, younger changes, but let's say younger is under 60, very often you'll have just what we call a soft rupture, where it's a fragment, if you will, come out and be in this channel. So we'll commonly do what's called a microdiscectomy, micro meaning small incision used in the microscope, where we just take away that offending piece. In that case, we don't really repair the disc, we just count on it to seal in and heal with scar tissue. We don't grow disc back, so all it does is fill in with scar tissue. Now, I brought some models of some other surgeries do when we actually replace disc tissue, like we do when we do many fusions, or like we do when we do disc replacement, but we don't typically do those surgeries just for a simple ruptured disc. Those are typically for other problems or second or salvage surgeries.
Okay, so Dr. Howard, before we go on to talking about minimally invasive spine surgery or micro spine surgery, let's say a person has only pain or perhaps only sciatica. Can we distinguish that from the person who comes into your office who actually has a neurologic deficit? Let's say someone comes in and they have low back pain. Almost everybody on occasion feels low back pain, but let's distinguish between a person with pain and a person who has an actual neurologic deficit, like a numb foot or they find that they can't control the muscles in their legs so well, or even bladder and bowel dysfunction. Now, don't you classify a person with pain perhaps differently than someone who has a neurologic deficit?
Oh, absolutely. As you know, pain is very common, especially spinal pain. Thankfully, but paralysis or major nerve dysfunction is much less common. But in my line of work, those are real red flags, meaning we have to pay particular attention and do a very definitive workup, usually with MRI scans, sometimes another test called a myelogram. But for example, if you have a progressive paralysis or weakness or a progressive neurologic dysfunction, for example, if you lose control of your bowel and your bladder, that can be a surgical emergency, meaning that if those nerves are pinched for longer than 8 hours before the pinching is taken away, that can result in permanent nerve damage and permanent dysfunction. So those are real red flags that are very concerning. If a patient has that, they need to present to a doctor immediately.
I see. So let's talk about the traditional, or what we could perhaps call open spine surgery, where we make larger incisions, as opposed to perhaps a newer technique where we make smaller incisions, perhaps use the microscope. Certainly, as an aside, all surgeons are trying to do more through smaller incisions. Certainly in plastic surgery, we're trying to do more facial rejuvenation and endoscopic forehead lifts, et cetera, with new technology and through smaller incisions. The gallbladder surgeon traditionally used to make a long incision to take the gallbladder out. Now they call it Band-Aid surgery, where they make little incisions and put a laparoscope in to take out the gallbladder. So I think the same is true for spine surgery. Isn't that correct? Definitely,
David. In the last 20 years, since I've been out in practice, it's really changed drastically. I mean, even a microdiscectomy, back when I started training, you still got a 2 or 3 inch incision. Now you would commonly get a 1 inch incision or maybe even smaller. Just like your line of work, we're doing more surgeries through tubes. We're doing it through what we call muscle sparing or muscle splitting approaches, where we're not devitalizing, we're not damaging the tissues as we go in, because we're able to do it through portals or through tubes. We're even able to do that where we put in some of our traditional hardware. This, for example, are the kind of titanium implants that we might use for a fusion. This shows a special plastic cage that we might put in to replace the disc when we do a fusion. But even this technique, for example, we're able to, for example, put this cage in many cases through a tube that we come in directly from the side. So we might just have a small little 1 inch incision on the side and do the entire procedure through a tube. And then the same thing in these screws. Might be able to just make what we call little stab wounds, little small punctures, and put all these implants in using X-ray guidance in a very minimally invasive fashion. So that's been the exciting thing in my field, is getting less and less invasive and able to do, in many cases, a better job, or at least the same quality of surgery they were doing before through much bigger incisions that cause more bleeding, more pain, a much longer healing time, more tissue damage. And that's been an exciting part of the evolution of my practice.
Sounds exciting. Dr. Howard, what do we mean by a compression fracture of the vertebral? It's of the vertebral body, right?
It actually is the most common, what we call insufficiency fracture in the body, probably because we have so many vertebrae. But as you're well aware, as we're all living longer, but especially women, where there's a higher incidence of osteoporosis at a younger age, we're more prone to develop what are called insufficiency fractures, where if you lose enough calcium from the bones, in many cases they just can't stand even normal stresses. But then if you have a fall, or sometimes it doesn't be a major thing, it could be a sneeze or a cough, but that's enough to compress the bone. One of the newer techniques that's really been exciting in the last 10 years is this one called kyphoplasty. This is a model of the balloons we would put in a vertebra. What we do is we insert these balloons through a special needle. We expand the balloon to create a cavity, and we inject bone cement in. That does two things. It restores some of the height of the compressed vertebra, and it gives us immediate relief of the pain because we've filled it and stabilized it with bone cement. And this nowadays is in many cases done outpatient, where the patient goes home the same day. So that's a really exciting progress and new technology that we're doing routinely now, and it's only been around for about 10 years.
Okay, so Dr. Howard, let's return to the differences between cervical spine disease and the lumbar spine disease. Do you commonly see, we talked about the famous quarterback who had or has some disc disease in the spine and is having a great season after cervical spine surgery. So is there a difference in the frequency or who gets spinal disease in the cervical spine and who gets a lumbar spinal disease? Do you see differences between men and women, athletes or obese people or young people, etc.?
David, not so much in terms of the neck versus the lumbar spine or the cervical versus the lumbar. What I would tell you, there's a couple definite known risk factors for disc disease, both neck and back. One is smoking is actually the biggest risk factor, which is not commonly publicized, but that's one of the major negatives of cigarette smoking. And the other is familial. It tends to run in families. You're much more likely to have a herniated disc, or specifically to have back or spine surgery if you have an immediate family member who's had it. So those are really two of the biggest risk factors. The other is experiential, or certain occupations, certain athletes are more prone, but usually it's a repetitive spinal loading occupation like a heavy equipment operator, bus drivers. Over 20, 30, 40 years of doing those activities, they're more prone to develop disc disease and ultimately maybe have back surgery.
Oh, excellent, Dr. Howard. Dr. Howard, I'm learning so much, and we only have a couple minutes left, so I want to talk about two more things if we have time. So we mentioned that back pain is so common. Neck pain is also fairly common. So how does one know, or how do you determine that a person can be managed conservatively or without surgery for their pain, back pain, and how do you distinguish between the person who needs an intervention or needs an operation?
Well, Dave, what I tell patients is that the great majority of people can avoid surgery and do avoid surgery. Even if you have a known herniated disc, for example, 85% of those folks get better with time and healing and rehab therapy. I'm a huge proponent of swim or water exercise because the buoyancy you have in a pool is so beneficial to the spine. But there's sequences, there's steps. Surgery is the last step. Normally patients will do a course of therapy, they'll swim, they'll take anti-inflammation medicines. They might try stage 2, which are special shots of cortisone in the back called epidural steroid injection. Only if all those things fail and they have severe pain that's disabling, and or if they have some persistent weakness or numbness, only then do we say, okay, you have to consider the final option, which is surgery.
Excellent. Dr. Howard, before I give out your contact information, I'm going to surprise you. I want to tell a story that's partly personal about Dr. Howard. I remember it wasn't that many years ago. I had an emergency case at the hospital here in town with a carpenter who accidentally put a skill saw across his forearm and cut many nerves and arteries and tendons. And it was late in the day, almost nighttime, and I needed an assistant, and it was an emergency. Dr. Howard just finished a spinal case. He volunteered to come in and help, and he was outstanding under the microscope. Excellent. As you know, I think that plastic surgeons and microsurgeons are pretty good under the microscope, but I gave you enough of a recommendation. I thought maybe you should do a plastic surgery fellowship, maybe when you grow up, because I thought you had excellent hands.
I appreciate the kind words.
Dr. Howard, board-certified orthopedic surgeon, fellowship-trained spine surgeon. You've been in practice over 20 years. If someone has a question or wants more information about spinal surgery, what do they do? Do you have a phone number? Do you have a website?
We have a website, markhowardmd.com.
Okay, markhowardmd.com, and you're here in Monterey, California.
Monterey, California. We're in the phone book.
Okay, you have a phone number we can hand out?
Yeah, 831-655-5380.
Okay, Dr. Mark Howard, 831-655-5380. Spine surgeon, board-certified orthopedic surgeon, Harvard Medical School. Dr. Howard, I love these segments where I learn a lot. Come on back, okay?
Anytime, David. Thanks
very much.
Thanks.
Once again, I'm Dr. David Morwood. I am a board-certified plastic surgeon, and this is Your Health television program. We're going to take a very brief pause for a very good cause.